small technical difficulties because he's on, but we can't get him promoted. So just give us one more minute. Folks just joining us, thanks for joining us. We are having one small technical difficulty and we need our chair to get started. We are just give us another 2 minutes and we will be rolling. Okay, so I'm gonna wait while our colleagues are still trying to get Edmondo on. We're gonna get we are going to work on either getting him to call in. We're not sure why we don't see him, but in the meantime, before we call the meeting to order, I'll wait for Edmondo to do that officially. But just wanted to welcome everybody, NAC members and our participants and our guests to this meeting. NAC members, if you can use the computer raised hand function if you have to make a comment. That would be fantastic. You can also write in the chat that you have a comment to make. That would be great. just to remind everyone that this event is going to be recorded, and this is also posted on the AHRQ website once it's available. Closed captioning is also available for this meeting. And if you need closed captioning, please click at the bottom of the screen. So today, we're going to begin with an update from our AHRQ director. We'll hear an update from AHRQ's Patient Safety Framework and the Patient Safety Action Alliance. And then finally, we'll get into a discussion about long COVID and our health system fragmentation. And for folks, just to remind all that if you'd like to make a public comment during the NAC meeting, you should make this request by emailing the National Advisory Council at arc.hhs.gov no later than 1 p.m. today. While we're waiting, I think we'll go around the room, and if you can all briefly do a quick introduction, we'll start that process. I'll start as I see you all on my screen. Komal, you're first.
Hello, everyone. My name is Komal Bajaj. I'm Chief Quality Officer for New York City Health and Hospitals, Jacobi North Central Bronx, and an OBGYN.
Great. Neil, you're next.
Hi, Neil Goldfarb. I'm President and CEO of the Greater Philadelphia Business Coalition on Health and Employer Coalition.
Great. Krista?
Hello, I'm Krista Hughes. I'm the founder and CEO of Hughes Advocacy, in which I'm a board certified patient advocate.
Jaji?
I'm Jiajie Zhang, Dean of the School of Biomedical Informatics at UT Health Houston.
Great. David Atkins?
Hi, I'm David Atkins. I'm the Director of Health Services Research at the VA.
Henry?
Hi, good morning, everyone. Henry Ting, cardiologist and the Senior Vice President and Chief Health and Wellbeing Officer at Delta Airlines.
Kathy?
Good morning. I'm Kathy Ivory, Associate Nurse Exec at Vanderbilt University Medical Center in Nashville and a registered nurse.
Mireille?
Hi, I'm Mireille Jacobson. I'm a health economist based at the Davis School of Gerontology and the Schaefer Center for Health Economics and Policy at University of Southern California.
David Schmidt?
Hello, I'm David Schmitz. I'm a family physician and professor and department chair at the University of North Dakota School of Medicine and Health Sciences.
Great. Carolyn Carney?
Hi, everybody. I'm Caroline Carney. I am President and Chief Medical Officer of Magellan Health. I am an internist and a psychiatrist.
Sherry?
Hi, good day. Sherry Lang, Deputy Chief Medical Officer, Centers for Medicare and Medicaid Services, geriatrician, internist, and rheumatologist. Thank you.
Andy?
I'm Andy Auerbach, hospitalist and professor of medicine at UCSF.
Great. And then I see Edmondo is on, so I'm going to turn it over to him and let him take over. And we're on. Can we lose you again? No, now we lost him again. Okay, so then I'll turn it over to Bob to introduce himself.
Hello, I'm Robert Valdez, and I have the pleasure and honor of serving as the Agency for Healthcare Research and Quality Director. I want to thank all of you for your time and your attention and the advice that the Council will be providing this coming year and throughout the coming future, because as I said before, once we have our teeth in you, we never let you go. And so we always try to bring you back and help us move forward. Today, one of the things I'd like to do is really share with you and celebrate the successes. Celebrating success is so important for an organization. And it's extremely important for an organization like ours that is about a collaborative commitment to building an equitable, high-quality healthcare system. You know, making 21st century care a reality for all in our society. my presentation will share a few highlights of some of the contributions of AHRQ's, what AHRQ has been able to achieve in 2022, pursuing its unique mission. And we go about our mission by generating science and actionable knowledge, by moving that evidence into the practice of medicine and healthcare, and also by monitoring the performance of the healthcare system and providing feedback on that performance through some data systems that have been extremely important for understanding our healthcare systems around the country. As you know, biomedical science is necessary, but it's insufficient to improving healthcare in the United States. AHRQ focuses on healthcare improvement through social, behavioral, and clinical sciences that are based in dissemination and implementation of actionable knowledge that's necessary for the adaptation, and delivery of innovative therapies. May I have the slides, please, so I can just share some of these wonderful achievements.
Yeah, we'll move on to Bob's presentation. What we'll do is we'll come back and approve the minutes after when we get Edmondo on.
Now, we couldn't possibly do our work because most of our work is through contractual arrangements and grants to investigators. And our Office of Management Services last year awarded 423 competing and non-competing grants for the organization. It's an extremely difficult process, as you know, working through our various requirements. And so this particular team has done an extraordinary job. It processed over 500 contract actions in fiscal year 22 that totaled more than $246 million. It also was a team that started to work through this situation of bringing employees back to work in teams and as a whole at 5600, our fabulous building. But we've developed new ways of working as we're working today in a hybrid, in a visual digital mode right now. We often are working now in hybrid, and developing that work in hybrid has taken some work. We've developed some telecommute, we've developed some new work policies, and we're really trying to take advantage of this opportunity, not only to retain our wonderful staff and maintain more morale, but also to expand these possibilities to reach out to more diverse talent pools that are all around the country. Next slide, please. Our Office of External Research, Education, and Priority Populations is where a lot of our external research programs exist. They awarded over $3.8 million in new grants that were funding 40 new research training grants and also career development grants. We have a whole panoply of different kinds of career development grants, both for the youngest of our scholars to the more senior of our scholars. We're also really trying to do something that invests in our care delivery systems so that they become learning systems by embedding healthcare researchers who are not only doing research, but also focused on the implementation of the evidence that is found and turned into actionable knowledge. Next slide, please. Our Office of Communications, of course, makes sure that these discoveries and this evidence is more widely known. And at AHRQ, we've had over close to 15 million page hits in 2022. And we're continuing to grow the visibility of the work that we're doing and getting that work out into our stakeholder audiences, whether it's healthcare systems, it's clinicians, or it's government officials who need to think about the health policy that takes place at the local and the state levels. Next slide, please. The Office of Communications is also trying to move us into the future. As I said, I've trying to look beyond the 21st century care into the 24th century care. And so they've been generating huge numbers of hits across the new digital opportunities for communicating information. The Office of Communication, I wanted to highlight, generated almost $2 million in media value on Twitter. That's a 16% increase over its 2021 activities. And we hope to continue to increase our visibility across the digital opportunities throughout the course of this next year. Next slide, please. Now, we have a cross-cutting set of activities at AHRQ, and that is really trying to achieve an equitable care delivery system. And to that end, we've convened this last year a health equity summit, which was intended to identify strategies that are needed to advance equity within our delivery systems. We've also been doing work within the agency using a variety of work groups. But more importantly, as I said, we fund efforts to try to find ways in which to improve our care delivery system. And so we've also released notices of funding opportunities for health services researchers who can help us both become more diverse in our funding and life experiences as we think about the problems we deal with, but also the kinds of issues that healthcare delivery systems must be aware of as we transform it to become more equitable. Next slide, please. Our Center for Financing, Access, and Cost Trends has a number of programs built around intramural programs, built around the different large data collection systems. In this particular case, I want to just highlight a few from the Healthcare Cost and Utilization Project, known by most people as HCUP. Now, we've had some really amazing pieces of work by our internal research community and those who developed the HCUP database. I want to bring to your attention the work that's been done on rural hospitals, an area of the healthcare system that is in dire need of assistance and focus. We've also been doing a lot of work on maternal morbidity and mortality, issues that are of high priority to this administration, and that AHRQ can make contributions towards improving the care that's provided and delivered across our country. I hate to say it, but the United States is not one of the better places to have a baby. And it's even worse if you come from a racial and ethnic minority community. So what we're doing today isn't working. We've got to fix it. We've got to figure out how to make it better and do it better. Next slide, please. So the work of HCUP continues, and we've developed new data. We've added and updated data throughout the course of 2022. And as a result, we've also been able to put out really time-sensitive statistical briefs. And I really want to thank our staff who are trying to stay on top of all the activities and issues that are going on across our country. Next slide, please. As I said, we build around several large databases, and the next is really the Medical Expenditure Panel Survey, or MEPS as it's more often called. We've had a very active year there, also by adding new data and updating the data that's made available to the public. We're working on improving our website so that it's more available and easier to use. And we've put out a large number of statistical briefs and working papers, and of course, a chart book on health insurance that is now in its 26th version, I think it is. Okay, the next slide, please. Again, not only do we collect the data, but we also analyze the data and also make that data more available to researchers throughout the country. And some of the really important work that went on in 2022 includes these examples. An example of this work that was done to look at high job flexibility and paid sick leave and its access to healthcare and its relationship to the access to healthcare among U.S. workers. We've also done some amazing work looking at how changes in preventive services by race and ethnicity after the Medicare eligibility kicks in occurs. That there's just been a large number of insightful pieces of work by this group that I encourage many of you to look for and to look up and to read and to enjoy. Next slide, please. Our Center for Quality Improvement and Patient Safety, CQIPS, held a huge event with the secretary. It collaborated with departmental agencies, our partners at CMS, our partners at FDA, and others to really bring to the fore the issue of patient and workforce safety. The healthcare system, as you well know, experienced great stresses and strains throughout the COVID period. And as a result, more than a decade's worth of progress, slow but steady progress, was lost. And in fact, we've often gone in the opposite direction with regard to patient safety events. So now is the time to regroup. And we've been given the charge by the secretary to co-create a national healthcare system action alliance to really advance patient and workforce safety. During the course of this last year, we also released a report to Congress, our annual report to Congress on national healthcare quality and disparities report. Again, I can summarize that report, which has been going on for decades now since the release of Unequal Treatment, the report by the National Academy of Medicine, that highlighted the disparities in our community and the disparities of quality in our community. And that report continues to say, we need a lot of work. We still are far from what we can do and what we could achieve. And what we're doing isn't working. We need to do something different and something better. Next slide, please. The Center for Quality Improvement and Patient Safety has also done a number of extremely important patient safety projects that have been completed this last year in 2022. A particularly important one is a program on safety in the ICUs, preventing central line bloodstream infections and catheter-associated urinary tract infections. But it's also completed a safety program for improving how we use antibiotics, which increasingly are problematic as we've used them widely and without the kind of shepherding and thought that's been necessary to keep them from becoming ineffective. Next slide, please. Our Center for Evidence and Practice Improvement has also been focusing on effective healthcare by really deepening our partnership with PCORI, their evidence synthesis group, and we now have a commitment of over $60 million to support evidence-based practice reports over the course of the next 3 years that not only focuses on the research that evidence that was produced by PCORI, but by all of the evidence that's available in the literature.
I think we lost Bob for a moment. My guess is the connection, he's at HHS today, I think, so I'm not sure what happened with the connection, so This seems to be a gremlin kind of a day, but hold on for one moment while we bring Bob back.
Jamie, should we use this moment to interrupt our programming to let Edmondo approve the
I was
minutes?
thinking the same thing, David, if you don't
Good
mind if
idea.
I do that.
Yep.
So yeah, apologies. I had some firewall issues here that we're still working through, so I'm jumping on my iPad. But one, I wanted to kind of thanks all for being here, and I wanted to officially call the meeting to order while we have the opportunity to do so. As well as unless Bob is back on, which I don't see him, we may even have a chance to approve the minutes while we're here. So I'm going to assume that everyone had a chance to review the minutes from the last meeting. And so with that, are there any changes or edits requested to the minutes as presented? Seeing none, all those in favor of approving the minutes, just put your hand up on the little Zoom thing. There's a little hand raise thing, or you can raise your hand too. That also works. I saw you first. Okay. All right. So minutes are approved. You want to oppose, by the way, to the minutes? All right. Good. All right. So minutes are approved, and we're gonna keep working on Bob. While we do that, so we've I think most of the housekeeping things Jamie has already done. The way we'll take questions is by the little hand raise function within Zoom, and all the NAC members should keep their video on if at all possible, unless you're driving or something dangerous, don't do it then. But otherwise, keep your video on. Also for public comment, you have until, when do you have until, Jamie, to submit for public comment?
1 p.m.
1 p.m. So you have until 1 p.m. to submit for public comment. And what else? You've already walked through the agenda.
The only thing I didn't do was video settings.
Oh, the video settings part. Let me go back up to that. What was the video settings part of this?
So if you can, so just to remind NAC members, you can change your video settings so you can view all members who are speaking by going to the video settings and click on an item that says you can display 49 people at a time. So if you haven't already done that, feel free to do that.
Thank you. I missed that part of my agenda. All right, so are we close to getting Bob back, or should we move forward? Where are we at?
Not heard from him yet. So give us a couple more moments.
Looks like it's not just me having issues today.
As I was saying, we're of course it's the one day that we're all virtual, and there's some technical issues, but we'll work through it and we will still make up the time.
Jamie, not trying to do a coup, but I think Erin and I are here if you want to go to the next.
Yeah, I was thinking that, David. I just want to see if we're
Give me
close.
yeah, give me one moment and give me
Of
one more
course.
minute, and then if not, that will be our plan, is we'll switch. Okay, given that I haven't heard from him, I'm assuming there's some computer technical difficulties at HHS. So what I'd like to do is let's switch to the next section, and we'll and then we can come back to Bob's presentation.
We'll circle back to Bob. Okay, good. So let's bring in Erin and David to talk about excuse me, our patient safety framework and patient safety action alliance. Erin Grace is acting director for the Center for Quality Improvement and Patient Safety. Dr. Myers is deputy director for policy and strategic initiatives. So let's give some time for these folks to give us this update. And I think we might have some time for questions at the end of their presentation.
I'll start us off. Next slide, please. This is Erin. There we go. I was going to say I can't see myself, but now I can. As some of you know from prior presentations to the National Advisory Council, IHI convened 27 organizations, including 6 federal agencies, to form the National Steering Committee, or NSC. The NSC was co-chaired by Dr. Tejal Gandhi, then of IHI, and Dr. Jeff Brady, who was then the director of the Center for Quality Improvement and Patient Safety at AHRQ. The NSC developed Safer Together, a national action plan to advance patient safety, with 2 accompanying documents, a self-assessment tool and a resource implementation guide. These were released in September 2020. Last year, the NSC made a declaration to advance patient safety, urging healthcare leaders to recommit to patient safety and implement the National Action Plan. The National Action Plan is based on 4 foundational areas that you see here: culture, leadership, and governance, patient and family engagement, workforce safety, and learning health systems, all of which need to be present and are interdependent to provide healthcare that is of a high quality and that is safe. Next slide, please. I want to share with you some recent AHRQ patient safety activities, which you can learn more about from AHRQ's website. And I think links will be provided in the chat or in the minutes. And some of these Bob had already mentioned. As you know, advancing diagnostic safety and quality is one of AHRQ's key patient safety priorities, and Congress increased AHRQ's funding in FY23 to advance this priority. As such, we recently published 2 new diagnostic safety requests for applications, an R01 and an R18. And these are different from the Diagnostic Centers of Excellence that Bob mentioned, which were awarded last year. We intend to fund 10 grants in total in FY23 under these 2 RFAs at $500,000 a year for 4 years. We've also been working to summarize the results of our investments in patient safety and have posted the first in a series of patient safety project highlights, which are summaries of AHRQ-funded grants and contracts on a specific patient safety topic. And our first highlight is related to our work in engaging patients and families to improve safety. And I see Amy is putting links in the chat. If you could go to the next slide, please. Our Healthcare Associated Infections Division has continued its large-scale implementations of projects and produced 3 toolkits last year, which Bob has already mentioned. If you can go to the next slide, please. Recent patient safety organization or PSO activities include release of a common formats for event reporting diagnostic safety version 1.0 in May and supporting documentation that was released in the fall, and release of the 2022 Network of Patient Safety Databases dashboards and chart book, which included a supplement on falls, which is new for us. Now I will hand this off to David, who will refresh everyone on the health system patient safety convening that was hosted by Secretary Becerra in November and our plans for follow-on activities. Thank you.
Thanks, Erin. Next slide. Since Bob outlined some of these activities during his overview, I'm going to try to go through these next slides relatively quickly to allow more time for NAC discussion. But let me take a moment to thank Dr. Valdez for leading, even though he may not be here, for leading HHS in reprioritizing patient safety and convincing the Secretary to publicly recommit the department to the goal of healthcare systems that produce 0 harms. To do this, the Secretary, with assistance from AHRQ, convened leaders of the nation's largest healthcare delivery systems for a listening session where we heard from C-suite executives, safety leaders, and patient and family advocates about current barriers and challenges to patient safety and how we could overcome them together. At the convening, HHS announced we intend, sorry, I thought this was going to go quickly, that we intend to create a public-private partnership to move forward together. I'm gonna have to give up on my notes. Another technical challenge. Next slide, please. Additionally, as the last slide showed, we published an RFI, a request for information, to make sure that people who were not able to be in the room were able to share their ideas about how we could best make the Action Alliance have the greatest impact. This slide again shows that, as Erin said, the goals of the Alliance are to both co-create it and to focus on the broad areas defined under Safer Together. At the convening, we were sure to have patient and family advocates at the table, and the Action Alliance will do the same thing. Next slide, please. The Action Alliance is viewed or thought about as a community open to all and free with multi-directional learning. AHRQ itself will, and the rest of HHS, will use the Action Alliance to help coordinate and align our resources from what we learned from the public. There will be peer-to-peer learning about successes and challenges that healthcare systems are having in advancing patient safety. And again, we are committed to engaging patients and families throughout. Next slide, please. So what are we do? Where are we in at this point? Because there are some federal regulations to make sure that we don't favor one organization over another, to get the Action Alliance started, leaders from across HHS are working to create the beginnings of the Action Alliance. We're also working together to complete analysis of the request for information feedback on how the co-creation can be most effective. We're based on feedback at the convening as well as throughout the RFI, we are considering targeting the audience of healthcare executives and board members as the first group we work with. Without their leadership, we think this movement won't move forward. We hope to begin formal activities of the Alliance in April. And again, as I said, and Erin shared with you, they'll be organized around the key foundational areas. We posted a listserv announcement where people could sign up to be updated about the activities of the Action Alliance and get resources as they're developed. In the first month, we've had over 3,000 people sign up, which we take as a very good sign. Next slide. So we're ready for discussion. On this slide, there are a few questions that we'd love to hear and get advice from the members of the NAC, one more source of information as we build the Action Alliance together. I do want to point out the last question. AHRQ is very interested in the NAC approving a subcommittee of the NAC to advise the NAC and AHRQ on the structure and processes and initial topics for the Action Alliance. We want to ensure you that we see this as a short-term snack, probably just for the next 6 months, and having 4 meetings to help us both look at the RFI and understand, as well as the convening materials, to understand what's most important. As we said, think about how we can co-create a national alliance. And with that, Armando, I'll turn it back to you. Maybe we can leave this slide up.
Got it. This is great. Thanks, David. So do you want me to facilitate this conversation here?
I would greatly appreciate that, but Erin and I are here to answer any immediate questions that folks from the NAC have.
No problem. All right. So given what you heard from David and Erin, in terms of some work that's already been done, but really also work to still be accomplished, what are some of your thoughts in terms of how do we create this and co-create this learning community? I'll just take hands. People jump in. I think it will be really particularly interesting to comment on use cases where you've actually seen this work, where you've worked on it in some of your institutions, or engaged in some co-creation with other institutions as well. Well, I see your hand up first.
Thanks, Armando. Firstly, I think this is a really, really important initiative, and I think the emphasis on patient and workforce safety is really an important one. I think for me, in thinking about an Action Alliance, being very clear on the differentiator, as in what is the purpose of this alliance that is different or unique for so many other activities that are going on in this space, I think would be really helpful and perhaps then liberating, because we don't need to solve everything, but we are very good at potentially solving a subset of challenges. And so I'd urge those that are designing this convening to be really laser focused on what's the purpose.
Yeah. Yeah. What's the purpose? What's unique? Yep. Neil.
Yeah, as the head of a business coalition that both convenes learning communities and participates in some national communities, I think one of the critical things, building on what Kamal is saying, is also to have some sort of a charter of what are the expectations of group members. It's very easy for people to sign up for a group and just sort of listen in or ride coattails. I think for it to really work, you need to get some sort of commitment that, here's how often we're going to meet, here's the expectation about attendance, here's what we expect people to contribute, and maybe even have some agreement that participants sign saying, I understand what my obligation is. Otherwise, you have a constant stream of people coming and going and not contributing.
Yeah, makes a lot of sense too. Other thoughts on that in terms of the kind of the initial thinking around co-creating and operating a community like this, as well as potentially recommendations on how to implement from your own experiences, especially with this idea of what skills, what competencies, what capabilities are necessary to move this along. Kathy?
Well, before I lose the thought about capabilities and competencies, I would suggest that would need to focus on what the goal and missions of learning communities were, because those competencies and expertises will need to change depending on what the focus is. I think the other thing that I would say is, in addition to really defined and well-executed expectations, it would be well-defined and rigorous evaluation and updates on those metrics. So in addition to expectations of the folks who attend, what are we going to measure and how are we going to report it, and how is that going to be disseminated? And I guess my biggest example would be the early work in the early to mid 2000s that the IHI convened around perinatal safety. And they had some really good success having several common areas of focus with common metrics and convening teams around those.
That makes sense as well. David Schmitz.
I would just say, in the spirit of diversity, equity, inclusion, to make sure that the voices of the most vulnerable are also heard, even if they're relatively small numbers. And you mentioned prior organizations. The National Rural Health Association, I think, had a good structure for doing that, so that we avoided unintended consequences for those that were most limited or vulnerable in their current positions.
Important. Krista.
And, back to the learning community and what David was saying, you've got to have this patient voice at the table. They need to be heard. They need to feel trust. They've just got to be part of this community and part of the learning system, or it's not going to work. Like Bob said earlier, it's broken and things aren't improving. And the only way, in my opinion, to improve in this initiative is to have the patient's voice at that table and let them know they're heard.
I'm on my sitting phone. Right.
Looks like Bob's trying to jump on here. Part of what I'm hearing, both from David and Kristen in the last couple of comments, is one, engaging the voice of the patient, of course, and specifically making sure that we have the voice of vulnerable populations really engaged in some way here. I imagine that there's some evidence that probably that might work. I'm looking at question 3 where it says, what do we already know works? And I think making sure you have the voice of those that ultimately will really need to be engaged around this in terms of the outcomes for them. Having them at the table early on is one of the things that works. Dr. Myers, you're up.
I apologize for my technical difficulties there with my notes. One of the things I missed in that responds to what David and Kathy just said. Bob at the national convening shared with everybody his belief that none of us are safe until all of us are safe. And that has led to a commitment that as we advance patient safety, this whole project has to be, has an equity lens to it. And how do we do that? So David, thank you for the suggestions of groups to include, and Armando for underlining that about not only is it patients and family advocates, patient and family advocates for those who are most vulnerable. So thank you for that.
Makes a ton of sense. Just going to check on some technical things here really quick. Okay. So other thoughts, and this may be I guess your closing question here, because it does require an action item, it looks like. So should we, and I'd love to hear the NAC's opinion on this, because it's not necessarily a foregone conclusion to form a SNAC, right? That's something that we do launch, but it's not, again, it's not a foregone conclusion. You've heard you've heard the opportunity, you've heard some of the needs, you've heard some of the thoughts around what are the resources and so forth, in terms of types of competencies, capabilities, who should be at the table, who should have a voice. You've heard these things. What is being proposed here, I'm gonna just paraphrase, and please clean me up, David or Aaron, if I miss it. But what's being proposed here is to create a subcommittee of the NAC to advise on the structure and processes, and even topics for this Action Alliance. So just, I do want to hear, one, did I get that generally correct? And then two, I'd love to hear from NAC members on if this is a worthwhile use of time and resources.
So one of the things I wanted to I'd like to add is that a SNAC is not just our current NAC members. One of the things it allows us to do is invite in other experts, representatives, so of patient and families, of marginalized communities, to make sure we have those groups at the table. And it allows us to do this quickly and fairly and give us that kind of advice, which otherwise we might have to wait quite a long time to do. So this is a way to quickly do it under your jurisdictions, while keeping to the legislation about FACAs, to make it fair. So that's why we're coming to you.
No, that's a really important point. I think that may get lost, which is that we can pull in other folks into the SNAC and pull in some of that expertise, some of those competencies and some of those patient voices that we think will be really influential and important in terms of helping us advise on that structure and process and topics as noted in the question. Thanks for reiterating that point. I think it does need to be called out. Kamal, I thought I saw your hand up first.
Yeah, thanks, Armando. In general, I'm very in favor of a SNAC for the reasons mentioned, the sort of versatility, the nimble ability to, ask and answer questions. But I did have a curiosity. I was wondering who ultimately will run this alliance? Like, is there a group of people who have already been charged or based on the structures will be running the alliance? And I ask because I think that's helpful in sort of framing the SNAC and sort of, what it can accomplish.
When I said structures and processes, that's what we're trying to get to. AHRQ has some dollars that we are planning to put into this, but we can do it in multiple different ways.
So it's really full structure built. That's cool.
Yep. Can I see your hand up as well?
Thank you, Armando. Though I'm definitely in favor of having a SNAC, maybe the the question I might pose is related to what is it that we'll learn that we haven't learned thus far through insights or inputs from having the call out that went out. If the information that we think we're going to get through the snack is going to be different than what we've gotten through the open call out from folks from outside. I heard you got 3,000 folks responding to these things. So the question is going to be, is there useful information there that might help not needing to go through another 6 months of waiting versus jumping in at this point?
Armando, may I? So first thing for folks, I apologize if I misspoke. We got about 100 responses, many organizational. The 3,000 were how many individuals have signed up for the Tell Me More. So I wish we had gotten 3,000, or maybe I don't. The challenge, I think, Dr. Ramar, is that we have so many people wanting to do so many things, all of which have value. I think the members of the SNAC will help prioritize. And this, we are not seeing this as a one-year effort. We recognize that this needs to be multi-year, but how many years and what should those evaluation criteria be are questions we will ask the SNAC or ask the SNAC to help us with. But we will share the RFI results as well as a summary of what happened at the convening to help us really prioritize from the system perspective, the outside perspective, the patient and family perspective. There's too much to do, and what's the best way to prioritize?
Got it. One question along those, again, thinking logistics along those lines a little bit is, you know, you're proposing 6 months here. Is that, but you've got some momentum. You know, that's what I heard from you've got some momentum now. That's what I'm hearing from your presentation. Is 6 months the right time? Is that a little too slow? Does it line up well? Like,
did we just lose Armando? So Armando, I think we lost the end of your question there for a moment.
Oh.
I would say 6 months is not when we start this. What we are proposing to the NAC is that this is not an ongoing open, like we're going to keep doing this forever. If the NAC finds value in this and the SNAC is doing really well, we could extend it at some point. But we would hope to meet with members of the SNAC quickly. Erin's team, I know, is shivering in their boots when I say this, but the faster we can get this team together, we need to get moving. We're committed to moving quickly.
got it. That makes sense. Caroline.
Thank you. I think David, you took the words out of my mouth a little bit ago in terms of the SNAC's actions. I think the actions they could hit the ground running with would be to harmonize those 100 comments and see where there is a theme across those versus where there is something more specific that we should pursue. You know, going back to the comments earlier, this needs to have a focus. And I think that's number one, is harmonizing those comments. Number two is harmonizing where they want to go versus what we know and, you know, where we already are. And that provides the starting point for whichever direction the SNAC takes us. But I am in favor of the SNAC getting started ASAP.
Okay. Very good. Krista?
I agree with everything Caroline just said, and I too am highly in favor of this because I think it's just very important instrumental work that needs to be done quickly.
Sounds good. Is there any, other than kind of the questions of logistics, anyone opposed to this or just have, not even opposed, maybe that's too strong. Anyone just have some concerns that should be voiced here around this forming of a SNAC for this topic? Cool.
Thanks, Armando. I'm not opposed to the SNAC as mentioned previously, but one thing that I would like for the SNAC and AHRQ to consider is that, you know, the idea of, you know, harnessing multiple perspectives and inviting multiple perspectives, prioritization at scale, and including the most vulnerable voices, in and of itself is an important sort of skill and potential contribution. There are there are, sort of roadmaps on how to do this and how to do this well. But on a very meta level, I would encourage that as the AHRQ and SNAC is going through this process, if there are learnings or toolkits or guides for others who are sort of doing these large convenings, I'd encourage the group to sort of share that learning, you know what I mean, as this work around safety is being generated.
Got you. So there are some potentially generalizable learnings from this work. I think that David and Aaron, I think that's a reasonable charge. Other than that, seeing no other comments, I keep forgetting if we have to formally charge a snack or if we can just kind of launch based off of this conversation.
It's worth taking a vote.
Okay, so be it. Let's given the conversation and the proposal here to launch a subcommittee of the National Advisory Council focused on advising on initial structure, process, and topics for the Action Alliance, again, as described in this conversation. All those in favor, raise your hands. I'll take a visual. Yep. Got you. Yep. Any opposed? Any opposed? I think there's like a little thumb down emoji if you want to do an opposed, right? I'm not seeing any thumb down emojis. So given that, I think your snack is approved.
Thank you all. Okay,
So thank you.
Bob, to finish the proposal, I think he's back.
Is he
On the
back?
phone, I think.
I think we're going to skip. I think we're going to end up skipping Bob's presentation. Jenny, is that right?
Yeah, so I don't think Bob wants to go on. The problem is we are ahead of schedule, and so what I would like, and our other speakers are not going to be able to get on earlier. So that means that we're going to have a longer break. That's a 30-minute break then, from 12:30 to 1 o'clock. And so we just need to join. And so what I'll say is either leave your cameras on, or like if you leave here, please come back like 10 minutes ahead of time so we can make sure we can solve any of these issues that might happen.
Yeah, please don't do like me and wait too late to figure out you have issues. So we will come back promptly so we can stay on track afterwards. So 1 o'clock is when the next section starts. Come in 10 minutes early. If you actually drop your video, I'm going to leave mine on. But we'll see you at that time. Thank you.
Edmundo, I just wanted to say one thing. I've been on the telephone since I went off the Zoom arrangement.
Okay.
And I apologize. I don't know what the technology has done to us. I'll still give you the extra time. But I just wanted to say, I wanted to close up by telling you about some really exciting work that David helped lead, which is really a focus on how we reduce carbon emissions in the healthcare system. A primer was recently issued that has found great favor in the healthcare industry, because not only does it do good, but it saves a lot of money and it improves the quality of care that people are receiving. It's called Reducing Healthcare Carbon Emissions. For those of you who haven't seen it, I encourage you to take a look at it. The Preventive Services Task Force has also been supported by AHRQ and has put out a great number of final recommendations, a dozen of them, and put out draft ones, about 16 of them, and continues to be a valuable resource to our medical community. And lastly, I just wanted to end by saying we're celebrating the 25th anniversary of the Evidence-Based Practice Center program. And it's a program that was formally introduced in June of '97, and it has really been a flagship of AHRQ in moving evidence into medical practice. And I think we should celebrate the 25 years of its success and the many opportunities it's had for helping improve care in the United States. So thank you all very much. And we'll see you in half an hour.
Awesome. Thanks again. All right, folks. 1 o'clock sharp. So I'm not sure I have Dr. Ramar.
He's going to join late.
Okay, gotcha. Okay. No, you're right. Then I think we're excuse me, I think we're good to move forward. So let's jump in and get restarted right on time here. So we're going to spend this session this time together on the NAC talking about long COVID and as a way to frame up the fragmentation in our healthcare system and addressing that fragmentation. I think long COVID does serve as a really interesting use case around that and highlighting that. And once we dig into the details, we'll both see the opportunities to use it as a use case around fragmentation, and maybe even where some of the challenges are in terms of thinking about long COVID as that use case. But let's dig into that. What we'll do is we'll spend some time with both Maddie Smith, who's a long COVID patient advocate. She's a nurse in Virginia, clinical administrator for the PACE program out in the Mount Rogers area. And I was just really impressed by her comments and thoughts as she spoke at the patient panel at the Long COVID Summit. So we'll hear from Maddie. We'll also hear from Dr. Robin Weineck, who's served as the technical report writer for the summit. Dr. Weineck's a facilitator, executive coach, consultant, and works really healthcare and public health. And so we'll hear from both of these folks who are joining us here, and then we'll actually spend some time on report outs from the small group session that we had prior to the official start of the NAC meeting today. So we'll have those 3 sections, and then we'll jump into some discussion from that. So that's how the rest of this session will go. So with that, let's actually just jump right in. Let's start with Maddie and go for it.
All right, great. Thank you guys so much for having me. I'm really excited to be here. I think this work is so meaningful and important, so I'm just really grateful to be a part of it. As he said, I am from Virginia. I work and live in a small town. I'm actually from Richlands. Going back to the beginning of COVID for me, it was a Tuesday morning in September of 2020. I developed chest pain and shortness of breath, which is very abnormal for me. I sought treatment the next day like a wonderful patient. I waited a day, but I was diagnosed with what they thought to be a probable heart condition. The symptoms continued to worsen, so by Friday, I returned to my primary care. And after some cardiac testing, it was discovered that I did not have a heart condition. My primary was convinced that I was having anxiety and panic attacks, but finally, by the end of that day, I was actually diagnosed with COVID. I was pretty sick during active infection, but I was never hospitalized. When quarantine ended, I went back to work. But as time passed, the symptoms, chest pain, fatigue, shortness of breath, brain fog, those things continued with really zero improvement. The weeks turned into months, and I started to feel like maybe something wasn't quite right. I'm a mom to 3 boys, ages 7 to 3. I was working full time. So I knew that the fatigue was kind of normal, but things just weren't seeming to get back to normal like I thought they should. At first, I was pretty patient with those lingering effects, but each day, hopeful that maybe those symptoms would resolve. I sought treatment for my primary, but for several months was given no diagnosis or answers. About 9 months post-COVID, I actually even went to the emergency room. I was having severe shortness of breath and chest pain. I had been taking my prescribed inhalers, but I just could not get any relief. I was terrified that I actually had a pulmonary embolism post-COVID, and that was really my main motivation in going to the emergency room. The ER physician did not take me seriously in the least. She treated me as if I were drug seeking and even made comments to me like, "You won't be receiving any pain medication in my ER." Although my chief complaint was shortness of breath, the only thing that she ordered or that I was given in my time in the ER was a nebulized albuterol treatment, and I was offered steroid tablets by mouth. She refused to perform any further testing and told me I needed to follow up with my PCP. She insensitively told me that maybe I was just one of those individuals who couldn't get over COVID very fast. Ultimately, I ended up signing out AMA. I left more nervous and defeated than when I went. Many times during the journey of long COVID, I felt very misunderstood. I had gone to the emergency room seeking answers and really peace of mind more than anything else. I ended up paying a $600 ER bill for a pointless trip. And I know that I'm not the only patient who has been treated this way during the long COVID journey. Unfortunately, though, some individuals don't really have the ability or the energy to persist and advocate for themselves. After several months, I was officially diagnosed as a COVID long hauler due to the persistence of my symptoms. In blood work ordered by my primary care provider, abnormal values identified I actually had a thyroid disorder. My primary care instructed that I would be sent to an endocrinologist for further workup. I was hopeful that maybe I was on the right track at this point to feeling better. Not only were the physical symptoms taxing, again, I have 3 small kids, I was working full time, but I experienced debilitating depression and anxiety, wondering if I was ever going to feel somewhat normal again. I was trying to keep up with my 3 boys who each have a lot of energy. I felt like I could barely get out of the bed. Being a mom is extremely important to me, and being a boy mom certainly requires a lot of energy. I wanted to be present for everything and be active in all the activities that they wanted to do, but the fatigue made that extremely difficult. It was hard to keep up with them at the park or the playground or on the t-ball field as I was coaching them. I felt so sad and defeated because my desire to be the fun, cool, active, ever-present mom far surpassed what I could do physically. I felt hopeless and depressed, thinking that it may never get better. My primary care office tried for nearly 3 months to get me an appointment with an endocrinologist. Several endocrinologists remotely in my area were not accepting new patients. That was the first battle to getting an endocrinology appointment. The first appointment my primary care office was able to secure for me was with a physician 2 hours from my home, and the appointment was 18 months out. My primary care office continued to look to get me an appointment closer to home and in a better time frame, and finally got me an appointment that wasn't so many months out. It was with an endocrinologist 3 hours away, but the appointment was nearly 8 months out, so I was grateful to have that. Once I got established with the endocrinologist in July 2021, it was discovered that he discovered that I have Hashimoto's, the autoimmune thyroid disease. He was wise and helpful and explained that the viral load from COVID had awakened that immune disorder, exacerbating all of those symptoms that I had: the fatigue, the brain fog, headaches, and chest pain. Once I started taking thyroid medication, I began to feel like I was getting my life back. He was an answered prayer for me. Not only did he treat my physical symptoms by addressing the thyroid issue, he actually took me seriously. He didn't treat me like I was crazy. And that was just as important to me as what he did for me physically. Not only is the stigma of long COVID a huge barrier to patient care, so is the lack of access to care. Like I said, I'm from Richlands, Virginia, a small town, and the lack of specialists in small rural towns is a common occurrence. Fortunately, I'm in a position where I'm able to travel to my appointments, but for many people, it is difficult to take that time off work to physically travel long distances or to even have the gas money to make those trips. This barrier often results in many patients giving up on seeking treatment because logistically it is just too difficult. The lack of access to specialty providers is a huge deficit, especially for those rural Americans. When you feel that bad physically, it really is difficult to deal with the stress of waiting so long and traveling so far to appointments, and it just isn't feasible for some. Additionally, many providers do not truly understand the effects of COVID. Like I said, I had a very poor experience in the emergency room, And I didn't have a poor experience with my first primary care provider's office, but it was more that lack of knowledge and understanding about long COVID and the resources available. So when I found the endocrinologist who was able to really address my concerns, I was so grateful, to find a provider who did. I'm thrilled to have the diagnosis and the treatment, because that's really ultimately what has led to me getting on the path of feeling better. So I feel very blessed and lucky, because many long haulers haven't yet found the right answer to their recovery yet. So again, I'm really grateful to be here. I think this work is super important, understanding more of what we can do as healthcare providers and as a community to come together and to find those answers to address the stigmas and the deficits that really are preventing people from getting on the right path.
Well, thank you, Maddie. That's really powerful story, and particularly because you've got a clinical angle, right? So you're able to see things from multiple different perspectives as you tell your story. So I really appreciate that. Let's go to Robin. Then after Robin goes through what she's seen and shares some insights, we'll get a couple of questions just from a clarifying perspective for both of these folks here. So Robin, your show.
Thanks, Edmondo. I really appreciate it. And Maddie, thanks so much for sharing your story a second time. So the Long COVID Summit, as you know, was sponsored by AHRQ in conjunction with Tim Kane's office as a partnership with them to further AHRQ's efforts to support clinicians and health systems to provide patient-centered coordinated care for long COVID patients, to inform the senator's work in the Senate, and to inform the whole of HHS's efforts to address long COVID. Next slide, please. They started with some opening remarks from Edmondo, who served as the facilitator for the day, Senator Kane, Admiral Levine, who's the Assistant Secretary for Health, Ms. Barkoff, who's the Acting Administrator and Assistant Secretary for Aging at the Agency for Community Living, and from our very own Dr. Valdez. May I have the next slide, please? Thanks. So what you just heard was Maddie's story, her personal story. And there were several other patients on the panel, and what Maddie just told you about, very, very consistent across all the patients. So 4 major themes. The first, the truly debilitating impact of long COVID, fatigue, brain fog, in some cases an inability to work or attend school or participate in family activities, and in some cases accompanying mental health problems, depression and anxiety as a result of the long COVID. Tremendous challenges that patients experienced in getting the care they needed and the support that they needed. The months-long wait to see a specialist that Maddie just described was not at all uncommon. Challenges in identifying knowledgeable clinicians, lack of support for things like transportation, obtaining medical records, making appointments. And in some cases as well, the patients actually serving as their own de facto medical record, literally carrying their records from provider to provider, because they were seeing clinicians in multiple different healthcare systems and multiple different clinical practices. All of the patients described not being trusted or believed by clinicians. So clinicians who denied the experience of long COVID, clinicians who said this can't be long COVID because you don't have this one specific symptom, having the existence of symptoms denied by clinicians, being accused of illicit drug use or drug-seeking behavior, or being diagnosed with a behavioral health condition because a clinician could not find evidence of a specific physical problem. And then the last theme that we heard quite consistently, and you heard it here as well from Maddie, is the reliance on what I termed a clinician hero. So that one clinician who they found who not only had the knowledge, but was willing to go above and beyond. So one of the panelists described her primary care physician as spending 3 hours with her at a time for each visit. Physicians who are routinely making themselves available to patients outside of their appointments, clinicians providing extensive care coordination. And that finding that one clinician hero was really what's made an enormous difference for each of the patients. May I have the next slide, please, Josh? Thank you. So over the course of the day, there was a chance to hear from the patient panel, then there were some breakout groups. The breakout groups came back together for some conversation. There were a number of opportunities for action that were identified. The first is to convene specialty societies. One of the things we heard a lot about was that multiple specialty societies are each coming up with their own definitions of long COVID, their own guidelines, their own long COVID specific vocabulary, their own list of symptoms and body systems involved, and how very much clinicians need for there to be a single source. And so the opportunity to convene specialty societies to agree on a definition of long COVID, to develop a long COVID specific vocabulary, lists of symptoms, body systems, and the roles that different specialists, therapists, and support teams may play in caring for long COVID patients. I would point out that the National Academies is currently conducting public workshops to examine the current US government working definition of long COVID. That's helpful. At the same time, it's not quite what the participants at the summit were calling for. They truly were calling for bringing the specialty societies together. The other form of convening that arose as an opportunity for action is an opportunity to convene EHR vendors to address concerns that both patients and clinicians expressed about the lack of access to medical records and test results. As I mentioned, patients literally walking into a clinician's office with physical paper copies of their records, not at all uncommon. There was one clinician who was there who said, when I take care of patients who have been seen within one healthcare system, they've been kind enough to give me read-only access to the medical records, so at least I know what's happening. But they're going and getting care elsewhere as well, and I have no access to that information. So again, to convene EHR vendors. The second theme for action was on consolidation. A lot of concern from clinicians that they're spending a lot of time looking for information about long COVID, and a lot of time looking for information that they know they can trust. So there was a call for creating a single trusted source of up-to-date, vetted, turnkey information about long COVID symptoms, treatments, and resources that clinicians would have ready access to. A number of clinicians also called for consolidating the provision of care by creating centers of excellence for long COVID care, both because this would ensure the existence of a group of specialists who get it, as in understand what it means to be a patient with long COVID and are willing to help, but also to build a group of clinicians with deep expertise and experience in treating long COVID. The third theme of opportunities for action was to identify and clarify care pathways. There were calls for building intake forms and intake processes that could be completed by case managers, for standardized approaches to patient assessment. And in fact, one of the things I heard most frequently from the breakout sessions was, if I'm a primary care clinician, I don't necessarily know what kinds of tests each of these specialists would like to see run before they see my long COVID patient. And if I can't do those tests while they're waiting, while my patients are waiting for that first appointment with the specialist, it just makes the pathway to get their care much longer, because they go to a specialist visit and they get told to go have these tests and come back in 3, 4, 6 months. So really wanting to understand, what tests should I be running? When should I be running them? Which specialists should I be bringing on, and how to involve therapists? And then the fourth opportunity for action theme was on communities of practice. There was a real call for creating closer connections between primary care clinicians and specialists, including the ability for primary care clinicians to receive virtual curbside consults, or e-consults, to support their care of long COVID patients. This sense of needing that connection was pretty profound. I really heard lots of people talking about, you could do registries, you could do this, but the most important thing is getting us access to the specialists. And I'll talk about that again in just a minute. The other thing that came up as part of this theme was the opportunity to create geographically based communities of practice. So toward the end of the day, as you were listening to clinicians talk, both at the microphone and in smaller one-on-one conversations, it was so good to meet someone else who's working with long COVID patients. It was so good to learn more about how you're taking care of long COVID patients. You just told me about resources in my community that I don't know about. And it's so good to meet other clinicians who I can trust and send my patients to for care. So that need to create geographically based communities of practice. Josh, next slide, please. And the next one. So the conversation identified 3 opportunities for research. The first is how we might learn about demonstrated ways to bring together expertise from multiple disciplines to plan and deliver care. Over and over through the day, cancer care was cited as an example of this, where a cancer center might have oncologists, physical therapists, nursing, social work, pain management, and any number of other disciplines who are there, excuse me, behavioral health and others. And what can be learned from those existing models of care and applied to the care of long COVID patients? And as Edmondo commented, since the bigger theme is on fragmentation of care, what can be learned from those models to reduce fragmentation? So how might care teams be designed? What are proven ways to overcome communications challenges? What administrative support would be required? How have teams worked, if they have, when clinicians are distributed among multiple healthcare organizations and systems? And then intriguingly, one thing I heard several times during the day was, what might it look like if we did something like a tumor board? So the idea of, excuse me, having a way that a primary treating clinician would have access to have the case reviewed by a group of people with wide varied expertise and depth of expertise, so that instead of sending the patient to specialist and then another specialist and then another specialist, instead the patient would stay with one clinician, possibly a primary care clinician, who would then have access to all of that input from those specialists and from other providers. Next slide, please. All of which, of course, leads to the question of what a feasible financial model for the care of long COVID patients might look like. So asking questions like, what's the work that's actually required for primary care clinicians to manage this complex multiple body system of care when you're dealing with multiple long COVID patients whose symptoms may not look like one another? And then what compensation is required to support this work? The 15-minute reimbursed office visit is not really what clinicians are asking for here. Second, what financial models might support multidisciplinary collaborative care for long COVID patients? And then lastly, how might clinicians be compensated for the care of patients outside the office visits, such as e-consults or other population-based models of consultation? And again, ways to think about that beyond long COVID to the fragmentation of care. And may I have the last slide, please, Josh? Thank you. And then, Maddie spoke about her experiences of being not believed, of being not trusted when seeking care. And so there really was an opportunity highlighted for research that focuses on shifting the cultural beliefs of clinical practice to more positively supporting long COVID patients. And opportunities exist here to draw from the established field of doctor-patient communication, to draw from fields outside the typical realms of health services research as well, such as communications research, IO psych, and psychology of behavior change. So it was an incredibly rich day, and I think I will stop there and turn things back over to Edmondo.
I think there was one more. I do want to actually capture that one last slide.
You do? Okay.
Yeah, there were additional policy
No
considerations.
worries. I didn't know if you wanted to take the time.
I liked it, so I wanted you to go.
Sure. Of course, I'm happy to. So, Josh, it's the next to last slide in the deck, all the way down to the bottom.
Yeah, additional policy considerations.
That's okay. So what it talks about are 2 additional policy considerations that came up during the day. The first was related to disability. We heard quite a bit from multiple patients about their challenges in applying for disability coverage. Things like the state system and the federal system aren't consistent, many months worth of waiting periods, only to find out that their claim was denied with no requests for additional information. while they're unable to work, only having 2 or 3 hours a day in which they're capable of functioning. It was also an issue from the clinician perspective as well. You know, they're asking me to fill out forms. I have no way of telling you when someone will be able to lift 10 pounds or sit for an hour at a time. This isn't the kind of disability where it's easy for me to tell you what the path is going to be like toward people getting better. If I leave spaces on the form blank, then people won't get their disability coverage. But I can't lie, and I actually don't have the ability to answer the questions. So some real challenges there from the clinician perspective as well. And then the other policy considerations came from concerns about children. There was an 11-year-old on the panel who was there with their mom and spoke about their experiences. And one of the things that really became clear was the added challenges faced in the care of children with long COVID, because it also affects their development, their socialization, their schooling, and the deep importance of having schools involved in children's care to ensure their educational needs are met and that their disability needs are met in the school system. Thank you.
Thanks. Sorry for putting you on the spot there, but I thought that, you know, we do spend a lot of time on the clinical aspects and the science aspects of things, but I think all of this wraps together when you start thinking about that last component around the policies around disability. It all comes together, and I think, again, when you think about it from a fragmentation perspective, if we just ignore those because they're maybe not directly in our purview, we're contributing to further fragmentation of the system. We have at least comment on it and acknowledge that further work should be done. And also, I think we probably don't spend enough time on pediatrics conversations. I think they're still important, you know, especially in this case. So thanks for covering that. I want to open it up for NAC members if you have any questions or clarification for either Robin or Maddie, given their two presentations here. A comment from Neil. Is this, well, then I'm going to ask a question and ask the NAC members to respond. Is this, one is the story that you heard from Maddie, does that sound, you know, is that the first time you've heard stories like that, or is that something that, well, yeah, that's pretty consistent? And then in terms of Robin summarizing what we learned from the summit, anything that jumps out at you as, well, I just hadn't thought of that. That's a new one in terms of this topic. Let's start with Caroline.
Thanks. First of all, I want to thank Robin and Maddie for presenting today. And Maddie, your story is very touching and reminds me, unfortunately, of many in the healthcare system in general. With or without long COVID, it is discombobulated at best and challenging to navigate to get to the right services and ultimately the right diagnosis. I think what it speaks to is that long COVID is an example of what we can use to talk about fragmentation in the system in general and what the patient journey really is, what people are facing no matter where they start or what door they enter. And Robin, a quick comment on yours. Disability is a beast. I have worked in a state Medicaid office in my past, making those determinations and seeing splits in the system, information coming in that's piecemeal. It's awful to navigate all the way around. And reform there in the face of long COVID would be a victory for reform across the system.
I agree completely. One of the panelists spoke about how it took 10 months to get a determination that she was not eligible for coverage based on one extremely short conversation in which the primary thing that happened was that she was told that there were 500,000 people waiting for determination who were ahead of her in the queue. So it's a pretty rough situation for sure.
Yeah, and I suspect not atypical as well. Krista.
Agreed. Maddie, I'm a patient advocate, and so thank you for sharing your brave story. I agree with everything Caroline just said. Unfortunately, the system is so fragmented. You know, long COVID is just a piece of it, because as boots on the ground with patients every day, there is no trust. You know, care coordination, a huge issue. You know, access of care. I mean, rheumatology, access of care is 12 to 18 months. That shouldn't be, you know, not being heard, being dismissed. So your story is 100% accurate, and I apologize all you've gone through. The sad thing is, this is how it is in every single healthcare setting from birth to death, and change needs to happen.
Thanks, Krista. David.
Thank you for sharing your story, and I really appreciate it. As a rural medical educator myself and a family physician, I have to say I'm disappointed to hear that you had the experience that you did. It seems to me that when we look at rural access to quality care, it should be the services that can be delivered as close to home as possible. And whether we look at the patient-centered medical home or other efficiencies, having that continuity relationship with your patient, knowing your patient over time, and really coordinating and managing their care, including subspecialty care, is really at the heart of, it sounds like, the difficulties you had. Frankly, I would expect graduates of my medical education system as family physicians to be able to make the diagnosis of Hashimoto's thyroiditis, and if not, be able to work collaboratively with an endocrinologist without sending the patient off for a physical referral. So I do wonder, and I don't know that you saw a family physician, you may have seen another type of entry point to primary care, but I'll say this is perhaps one of the disruptors that we've seen with telemedicine. Our patients out there that are less resourced or less informed than even you are in describing your symptoms, getting sort of a suboptimal assessment of their diagnosis, which might delay their care and land them in an emergency room with higher costs and less efficacy. So I guess what I would say is I think this is a call not only with regard to long COVID and the difficulties associated with that specifically, but to Hashimoto's thyroiditis, you know, and how do we seek to strengthen the backbone of primary care that is most efficient, effective, and occurring right in your small town?
Well, so David, I'm glad you said it, because as not being a primary care doc, I didn't want to call out that that seems like something that a primary care doc should.
And I'll just say I'm an old enough family physician to remember when HIV was new, and it was an acute diagnosis, and people were dying of HIV. As it became more of a chronic illness to be managed, family physicians have been a backbone of primary care in rural places. And for example, when we were treating multi-drug resistant HIV in pregnancy in a rural town in Idaho, we were able to use something like Project Echo to have a subspecialty team to support that care out of the Seattle University. But we did it right there in a small dairy town. So I think there are ways to make this more efficient systematically, both with existing and new disease entities.
And I think you're also calling another point here, and we're going to get to the report outs from the work groups from this morning, which is can we not recreate the wheel here, reinvent the wheel, and take lessons learned, from times like the HIV, kind of beginning of the HIV epidemic and others. So that we can actually apply those learnings in this setting, and then also take that and generalize it. So I think that's a great call out as well. Let's jump into the report outs from the groups. We'll have report outs from each of the two groups that met this morning and discussed it. So before discuss the topic and a couple of key questions. Before we do that, I did see Neil jump in, so we'll have Neil jump in first, and then we'll go to the report outs. And Kamal, we'll start with your team after Neil goes.
Yeah, sorry, Edmondo, late on the trigger. A question for Maddie. Maddie, as a healthcare practitioner yourself, I'm really interested in knowing how your experience has changed your view of the healthcare system and your job, and how you are communicating with your peers now about changing the way they practice medicine.
Absolutely. I think that's a great question, and it brings up a great point for me. And this kind of goes back to a point that I would like to address on David's comment. I had 3 kids in 4 years. So for years, we joked that my primary care was actually my OB, because I had all those kids so close together, and I really didn't have a primary care provider. And I switched providers several times during the journey of long COVID at the beginning, because the knowledge just really wasn't there. I would say through that process of, 1, trying to find a primary care that was a good fit for me, and 2, what I went through in navigating finding a specialist appointment and those things, my lens has certainly changed, and I understand what it's like to be the frustrated patient who's really just trying to get some answers and navigate the system. I think, like we've all spoken to, the fragmentation. I work in geriatrics specifically. So when I think about my patient population, they can't hear well, they can't see well, they can't drive. They're very dependent on other people to make these appointments, to get them to and from the appointments, to understand what physicians are telling them what they need to do. And so I think for me, being a patient and the experience that I've had, my lens has completely shifted. And I would say empathy, because it's not that I wasn't empathetic before, but I think I just didn't really have I hadn't really experienced that frustration or that anxiety. Or, like I said, when I went to the ER, it was really for peace of mind. That whole ignorance is bliss thing. I thought, I have a PE. I just need some peace of mind. And I think patients are seeking that every day. And it's easy for healthcare providers who are, we see so many patients and we deal with similar things. It's easy for us to dismiss things and think that things maybe aren't as important. But to that patient, it's really affecting their whole life. And for me, experiencing that firsthand has completely changed my lens to a lens more, I would say, of empathy.
That's a great call out there. Let's go to Kamal. I'll get back to you, Krista. Let's go to Kamal so we can start our report outs. Each of you, the 2 have each group has 5 minutes to report out on your discussion in your groups. And then Krista, I do have you, so we'll circle back to you.
Thanks, Edmondo. I'd first like to again thank Maddie and Robin for being here and for their presentations and the generosity of thought. As I was hearing the opportunities for action identified through the convene, consolidate, care pathways, and communities of practice, so much of what Group 1 discussed sort of falls into different buckets. So that's great to see. So when we talk about long COVID as a use case of exploring how the system does and does not work, we acknowledge this is really an excellent opportunity to zoom out and leverage the learnings and opportunities to fix some of the other chronic challenges like hypertension and diabetes. We at the same time also acknowledge it's not exactly the same, because we have perhaps more solidified pathways and understandings for some of these chronic conditions that we don't yet have for long COVID. And when it comes to sort of where the millions of dollars should go, we explored some successes, barriers, and curiosities really based on our experiences thus far. As far as successes, we recognize that long COVID treatment hinges on a patient-centered, multidisciplinary, coordinated care approach. And some of the examples highlighted collaboration amongst various health entities, as well as the large patient networks who really have truly been instrumental partners as we learn more about this disease. As an OBGYN geneticist, and we recently celebrated Rare Disease Day, right? Sometimes patients with rare diseases will coalesce, and there's 50 or 80. This was really an example where thousands and thousands of people were sort of getting together to try to understand their symptoms. When it comes to barriers at its very core, we still don't have a uniformly accepted definition of long COVID. And current payment drivers are still focused on acute care and less on prevention. We also recognize that navigation around sort of the bumpy terrain of care delivery, like for other chronic conditions, is a major barrier. When it comes to sort of opportunities or curiosities, we were musing about, well, what is keeping the system the way it is, right? What are some of the direct and indirect short and long-term costs, and to whom, right? Even sort of thinking about almost like applying some of our own performance improvement tools, sort of a root cause analysis on what is keeping the system the way it is. Some other curiosities were, well, how do we keep primary care engaged in this process? Something that I think was beautifully articulated in the recap. We also recognize that solid clinical pathways are crucial, and what are best practices for keeping folks current on these evolving best practices is something that is an important question to answer as we move forward. So where to spend the money? As a guiding principle, we recognize that it must focus on expanding access, not just sort of where to be seen and by whom, but also making it easier to navigate the system once folks are within our complex systems. And so here are some potential ways to spend the money. Build digital solutions that help patients navigate where to go. Expansion of the AHRQ developed care plan tool that is patient owned, right? And includes not just a symptom diary, but really what are the tests and therapeutics that have been tried, so that no matter where patients and families go, their journey goes with them. Support for innovative solutions that keep primary care folks engaged. Exploration on a macro level as to what are the forces that keep the system where it is. Solutions that support sort of the intelligence and competence of care delivery teams. And then somewhat adjacent but important point to consider, recognizing that workforce is key to functioning systems, characterizing the impact of long COVID on staff workforce itself. I'd like to open it up to the fantastic group one to see if you have any other comments or questions or thoughts.
Folks, please, if you guys were in that group, please jump in. Let me just, because I don't think it was placed up for the rest of the group, so the NAC members know, but the two questions that were asked around, I don't think we framed that up. The two questions that were actually asked around this topic of long COVID as a use case around fragmentation of the healthcare system are: one, reflect on your experience with healthcare delivery systems to identify ways AHRQ can address the issue of fragmentation using long COVID as that use case. What are the challenges and opportunities? And then two, because Kamal was referring to how would you use the money, right? So, our expertise is in research, practice improvement, data and analytics. So if AHRQ had a big pot of money, how should NAC, us, advise on prioritizing efforts? What are the important research questions that should be answered? Are there tools or practice improvement efforts that would be helpful? Are there data we should be collecting and buying? And if so, what? So those are the two questions, just so the rest of the group can know what questions we are framing up. But other folks, to your point, other folks in the group one want to jump in and add anything to the summary. Very good. You'll have time to comment afterwards as well. So it's okay if we don't have them just yet. Kathy and Caroline, I can't remember which one we had decided was actually going to do the report out. So please jump in.
I'm ready, unless Caroline's here. So and wants
Kathy,
to do
go
it,
ahead
so.
and I'll add color commentary.
Excellent. Well, I'm going to just say that much of what Kamal covered was also covered by our group. So I'm going to try to amplify a little bit about things that we concentrated on pretty highly. One was the overall need to define what we mean by fragmentation and the acknowledgement that care across all settings in healthcare across the board is fragmented. So to the points that were already made about other chronic diseases, had us highlight that that long COVID should be considered in the context of chronic disease. And like other chronic diseases, we do have an opportunity to think about it from, I think Kamal, you mentioned it, from the, the 360-degree view or the higher level view on what fragmentation means. We talked a lot about access needs across the board, particularly in rural underserved areas. Fundamental need for sharing longitudinal information and data across settings. The element of trust, and I really want to applaud Maddie for bringing that up in your presentation, and not only trust by the patient or the consumer in that they are being heard, but trust from the provider perspective in what they're hearing and their competency to accurately listen and diagnose long COVID. Patients' ability to access information, the whole need for a network of specialty expertise, understanding that should be close to home. And focus on diagnostic errors, and that really goes into that came up in our discussion of funding and priorities related to funding. How can we dig in a little bit more to that whole domain of diagnostic error, and how long COVID may not be diagnosed timely or at all, or how we might get at that. And then a population care perspective as part of coordination of care. So from individual cases to population management. And then going down to how we might advocate using $20 million, which we acknowledge is not all that much, but we'll take it and we need to use it. How again, focusing on diagnostic errors, how we can use the many data sets that we have access to collate what information we have or what data we have into information from which we might make decisions. And I think an idea from our group that got quite a bit of traction was taking all of that data and using kind of a crowdsourcing, consumer focused approach to also use the data that our patients and long COVID folks are generating through non-clinical channels to consolidate around what is a good consensus definition of long COVID. We brought that up earlier, and do we have an opportunity to use disparate and multifaceted data sources to come to that conclusion? And I think that's about it. I think we talked about a lot of the things that group one talked about, but I'll ask my group to jump in and clarify others that I missed.
I'm going to quote Edmondo and say we should take that consumer intelligence approach to figuring some of this out. I thought that was a really terrific point. I would add one of the things we talked about also in potential models that already exist, like Project Echo, in terms of having a framework of specialists when we can't get specialists in rural areas as part of our discussion as well. Otherwise, I think Kathy checked off all the points on my page as you were talking.
I want to double, thanks, Colleen, because I that quickly forgotten the consumer intelligence one. So thanks for reminding. And I want to double click on that because since the other folks that weren't in our group, what were we talking about when we were saying kind of, I was summarizing it as consumer intelligence, but really what was brought up was there may be a whole, there are actually not maybe, other data sets that are not traditionally used in health services research, but they are used in terms of understanding consumers that may be really applicable here. Even beyond kind of our social determinants types of like, zip code and all those kind of things. But there might be a whole set. So what, for example, if you were looking at this problem from the lens of a Google or an Amazon, how would you think about it? Where are the data that you would access? And how do we start to incorporate those kind of data into our approaches to optimize care delivery, collaboration, trust, flowing through the system, all of these challenges that we've identified in terms of the fragmentation. Anyone else from our group that wants to add here?
This is Dave Atkins. The only other thing was the possibility of funding sort of PBRN type models to learn from clinics, and also some of the health systems work that AHRQ has done to look at from best practices across health systems that seem to be tackling this well.
Sounds good. All right, so that is our summary across both groups that are reporting out and that had some conversation earlier today. Before we jump into further discussion, Krista, you were up, so I'm going to pull you back to the stage here.
I was just going to echo on a comment that Maddie made about empathy and compassion. I do a lot of role plays with my doctors, with my client stories, and they always say, I didn't think about empathy because they say they're just not taught how to do that. And Maddie was correct when she made the comment, until you are that patient that's frustrated or having errors or can't get appointments, healthcare professionals don't know how a patient feels. And empathy, in my opinion, needs to be something that should be taught. It needs to be something that is considered.
Yep. Great, thanks for that. I think that is, again, is one of those themes here. So we're going to open it up at this point, just for a general discussion around this topic. What if just thinking, and I'll give you a minute or two to just think through this as I start to real time come up with themes that I'm hearing. What are you hearing? What are the themes? What should we be focused on? Where should we be hunting? What are you hearing from Maddie's story, from the summary of the summit, from the report outs from your groups, from just your experiences, out there in addressing multiple different illnesses, but certainly long COVID as well. What are we advising NAC as a NAC, advising AHRQ in terms of whether it's a research agenda, whether it's a convening opportunities, tools, and optimized practice. What's our advice here, really? So a couple things I heard. What I find fascinating, this is just partly from being in kind of a transformation and innovation space. I always find it fascinating where you find opportunities to learn from other settings or use cases that may not immediately come to mind as you think about the problem that's in front of you, right? And you say, wait a minute, that sounds like that general model may apply into this setting. So I was, and we talked about it in our group, I was fascinated by this idea of comparing long COVID to cancer care. And what are those similarities where, wow, that may actually work. There's definitely challenges where it may not work. I mean, let's be clear. But this idea of a tumor board, for example, imagine you can build a remote, virtual tumor board of some sort. This idea of navigation and care navigation that's much more this idea of care pathways, which is also very common in oncology and maybe not as much in other areas. All of these, could very well apply here and could be lessons learned outside. Now, part of the challenge, and what I find interesting with oncology, as opposed to maybe diabetes, let's take that. With diabetes, I both know really well how to diagnose it, as well as I understand treatment progression whether or not my treatment is being effective, whether or not it's actually time to escalate my treatment. All of these, it's actually pretty straightforward in diabetes. In oncology, it actually is not. It's actually much more complex in terms of both the diagnosis. There's a lot of molecular data. It gets complex, and then treatment progression in terms of pulling the data in. You need the molecular piece, you need pathology, you need imaging, you need all of these pieces. It actually it's very complex in oncology. It's not necessarily straightforward, and it's not easy to just have a blood test and actually whether or not you're doing well in terms of you're managing that. And it sounds like long COVID is actually more, if you're gonna put those two on the ends of the spectrum, oncology, cancer care, and diabetes. Sounds like long COVID is closer to cancer care in terms of understanding that treatment course and those care pathways, those clinical pathways. So that's a couple of things that I pull. There's a lot more in there, but those are a couple of things that immediately came to mind. Let me pull up Jaji here.
Okay, so from Maddie's touching story, I saw two problems that we are fully aware. Number one is access to care, right? Number two is diagnosis. So both of this can be potentially enhanced or even partially addressed by technology. I don't know what you are doing over the past month or two, and the ChatGPT is everywhere. And I don't want to advertise anything, but again, I just want you to know that technology is there to do a lot of things, a low-hanging fruit, and especially provide diagnosis of rare disease or symptoms that we do not fully understand. I think technology is there to do this. And the second one is for telemedicine. So we will not expect a lot more real physicians in the remote areas anytime soon. I think that may never happen. But technology can actually do a lot of things that the physician can do remotely, and especially with combination of technology. Basically, telemedicine and AI together can do a lot of things for the issues we saw from long COVID.
Yeah, it's a great point. I know we're both technology people, Jaji, but I want to caution that technology is not necessarily a panacea and it's going to solve all the problems. However, there are definitely some opportunities that are probably haven't been fully optimized from a technology perspective. I agree with that. One example, during the summit, someone had mentioned that they work in a rural area as well, and folks kept talking about telehealth, and they're saying, "Hey, my folks just don't have broadband access," which is understandable, right? They just don't have it. Okay, well, but what I just heard from Maddie is that she's traveling 2-3 hours to get to an endocrinologist. Well, so why don't we combine the two challenges? So let's say Maddie's in a rural area, she's got to travel 2 or 3 hours, and she doesn't have broadband access in her home. Well, can she travel 30 minutes to a nearby clinical setting or site that allows her to actually have access to telehealth without actually having to build a broadband in her home, right? So can we pull those concepts together so that we both make it easier on the patient, but also leverage technology, even in those settings where it may be otherwise more challenging. So those concepts have to come out of some of these thoughts and some of this work. So thank you, Taji. Caroline, you're up.
Thank you. I might be jumping to a potential solution, but I have the really great opportunity to work with a company called PsychHub. And one of the things that we do is get evidence-based information out about mental health disorders. And we started putting videos on YouTube. All of the credit goes to Marjorie Morrison, who's the CEO. They now get about 1 million hits a month on evidence-based information about mental illness, whatever it might be. So if I have anxiety, I'll type in. And what's begun to happen is a partnership that PsychHub has with YouTube to get their information coming out first, so that the evidence-based information comes out atop of all of the other stuff. And so as you talked about that consumer approach, Edmondo, that immediately came to mind for me about unique partnerships with organizations out there who do help, get the source of truth or the evidence base out there. Now, what's happened with that information is health plans are saying, okay, if PsychHub puts evidence about mental illness, we can use that same thing to help refer them to the right providers. And so that's another link, right? So here you could put a long COVID information and use some of that information to help get people to a center of excellence or the right provider learning community, whatever that might be. So I went to that thinking about how applicable that model could look here.
Yeah, I think it definitely is applicable. One, so as I think about it from an advice and an advisory perspective here, we both talked about new and unique sources of data, but I think what Caroline's also highlighting a new and unique collaborations that maybe AHRQ hasn't participated in before, but maybe this is an opportunity to think about it, to think about health in ways that actually convenes and brings in, from a collaborative perspective. YouTube, I don't know what that looks like, but have we actually given them a call, right? In terms of what is it? What is it? AHRQ?
I'd suggest pulling Marjorie Morrison into the conversation. She works with SAMHSA quite frequently. Yeah. And, if you look at long COVID and mental fog and those sorts of things, there's definitely a link. And Maddie's story about someone telling her, it's just anxiety, so I think that we could pull that organization in to pick their brains, and they have a very close collaboration with SAMHSA, so they're in the family.
Gotcha. Yeah.
I have to drop, unfortunately. Thanks, everybody.
Thank you. No, that's great, and it's even better that we've already got an HHS link to some of these kinds of unique collaborations. Dr. Schmitz.
I just wanted to respond to your idea around the use of telemedicine, the broadband issue, and the referral system, and supporting really local care as close to home as possible with either telehealth or teleconsultation, which are really two different things. And I think one of the things that makes them different from each other is, frankly, payment. And so part of what I think our discussion and the potential research methodology ought to get to is, how is payment mechanism influencing the practice or the actual delivery of care within systems-based practice analysis. And we have something that is being looked at right now, and that is primarily medication-assisted therapy of opioid use disorder. There's a lot of studies right now coming into the literature, both pre-COVID and during the pandemic, with regard to modeling opioid use disorder treatment in very remote and rural and underserved areas because of collaborative models, which include telehealth. And so maybe instead of having centers for excellence, what we really need is decentralization of excellence. What is the social accountability of a center for excellence to reach out and collaborate with local access partners so that patients wouldn't have to have either a 3-hour drive, or, it'd be great if everyone had broadband, but in lieu of that, what if we really had collaborative models that had sensible payment mechanisms that could help support at least the costs of delivering appropriate care?
It's a great call out, completely appropriate, and as Robin will mention, absolutely came up in the discussion during the summit as a critical enabler and of any model we want to move forward. And if it's not an enabler, it ends up being a critical disabler of any way we want to actually move forward. You're not going to be able to navigate the optimal approach to these care models without addressing the payment. If you leave that off the table, you're kind of dead in the water. I'm not sure how you pull it off. So I think it has to be a takeaway here from the work that we're doing. Did I, Kathy, you're up.
Okay, yeah, I just wanted to just amplify a little bit what I heard from David and from Caroline into a point that our breakout group discussed and I didn't bring up, and that was the need to really look carefully at care models and the different aspects and makeup of care teams and how they contribute to outcomes. And I think reimbursement is a key piece of that. We talked about that from everywhere, from the need to look at that from in-hospital care. I know David mentioned from being in rural areas where patients may need to get transferred into a higher level of care. Sometimes that doesn't happen because of current staffing shortages and things like that. And I think the other thing that I would highlight is that these care teams, given our discussion today, probably are not just clinical related care teams, but they're social services related care teams, from the coordination of disability to behavioral health services, which is certainly clinical, but to transportation and housing and all those other things that make care access so complicated. And I should have remembered to bring that up before and wanted to make sure we talked about it.
Great points, actually here. Neil, I see you.
Yeah, we've talked a lot about urban and rural and access, but I want to just be a little more explicit about questions of equity and make sure when we talk about COVID, looking at Maddie and hearing her story, Caucasian healthcare provider who experienced tremendous barriers to getting care. Well, now imagine the inner city person of color and what they might be going through. And so as we think about these solutions, I just want us to be really sensitive, or to invest some of that research money into really understanding how long COVID may be disproportionately affecting minorities and people without insurance and other sectors of the population. It started with lower rates of vaccination and lower access to care in general, and then we have long COVID. So I think we need a better understanding of how that population is being affected and what we can do to help address access for them.
Great call out, and obviously very consistent with departmental goals. In terms of having, at least my interpretation of it is, having an equity lens, kind of in a horizontal across everything that's done in the department. So I think that would be consistent for this work to continue to have that equity lens across all this work. One person I haven't heard from is Andy, so I'm going to call you out on this, even though I know I'm putting you on the spot here, buddy.
No, I've been listening, Edmundo. I think, and I just echo what people have said about how the long COVID as a disease is just uncovering all the problems we have with coordination of care and access to care, both for general medical issues as well as specialty care. And I think there's lots of technological things that sprung up, were springing up before the pandemic, which accelerated partially. The part that I've been, I think the thing that is fundamentally different, there are two fundamentally different things about it. One is it's a new disease, which we don't know how to treat. So we don't know in some cases which specialist to send people to. I'm not even sure the long COVID clinics know in many cases. And then the flip side of that is the need to really do rapid discovery in that, which I think is a place AHRQ has lived pretty well in the past. So if we were going to start to advise what the next phase of long COVID looks like, at least from the AHRQ perspective, it feels like the learning health system model with a real emphasis on rapid collection of data synthesis, evidence reviews is a great place for us to be. I'm not as convinced that we are in a great place to discover the next immunotherapy or things like that. I think there's larger NIH agencies that are thinking about that particular question. But we should be in the place to start to gather the data, start to understand access issues, and start to say, okay, if you want to implement this, this is how you should do it. These are the best channels to share data quickly, share best practices quickly back to providers in health systems.
Yeah.
So even though I've been quiet to this point, I've been listening and trying to think about the sweet spots for AHRQ, because this is such a big, hairy, awful, and huge problem that I just want to get the best place to get started.
Mm-hmm. Yeah. No, it's good. It's a great point. And what was interesting in the summit is, you know, kind of highlighting, and one, I mean, the patient stories, including Maddie's, were very, very powerful and influential. But the summit also convened, you know, healthcare providers from across the state of Virginia, and clinicians, and hearing the very, very different perspectives. You've got folks who run COVID clinics, all the way through to folks who are you know, in rural areas, you know, being the really kind of the lone source of primary care for their population, and having to navigate that, and all in between. And what is that, and they're all coming together and seeing different things, similar things from different angles. It was really fascinating. But that was just Virginia. What is it like in Maryland? What is it like in Montana? You know, is it the same? Are there different? Are there other things that we should convene around? There's so many different, so much learning richness potentially from some of these conversations. I'm going to call out another NAC member here. So Henry, I'm going to put you on the spot here. Just pick your brain and hear what, you know, just what are you seeing? What are you hearing? What are your thoughts here?
I think my thoughts would echo what Andy has said. I think you know, this condition, whatever it is, has sort of surfaced sort of the blemishes that we've known about our healthcare system, and that linkage between primary care, specialty care, and that coordination of care. I'm not exactly sure we know that this is a new disease. I mean, this might be the inflammatory disease to any viral infection. And if I just replaced all the comments with multiple sclerosis, chronic pain, chronic fatigue, or POTS, the same issues exist in our healthcare system. So I would applaud any efforts that would look at this at a system level, because it's applicable not just across the equity lens, it's applicable for all of these conditions that require a multidisciplinary coordinated approach, which our healthcare system has a difficult time. I mean, cancer centers work because of that. Musculoskeletal centers work because of that. And there isn't that for many of these conditions that are rheumatic, inflammatory, or post-infectious.
Mm-hmm. Yeah, it's a great call. It was interesting. One of the more I don't know, interesting comments that we got during the summit was, and I don't know if you remember this, Robin, but an infectious disease doc got up, and she says, "Hey, you guys keep saying this is a new disease, and it's not." And we've had, I don't know if she was saying there was a coronavirus variant that we've had before that gave very similar inflammatory symptoms, and we've seen this all before, and everyone else scratching their head saying, "Really?"
Yeah, she specifically called out chronic fatigue and post-Epstein-Barr kind of viral syndromes, for sure, is very, very parallel, especially when you start from the point of whether or not patients are believed.
Mm-hmm. Yep. Yeah. So I think Henry, exactly. So then what that leads me to this idea of, well, then can we not recreate the wheel with what we've learned from some of those syndromes that we spoke about, that we know that have parallels or close similarities, but also can we then launch from there, because those aren't optimally cared for either, right? So it's not that we want to just replicate those models, but we haven't gotten that right. So how do we take the whole conversation forward based on those learnings and the learnings that we're having from our engagement around this kind of disease syndrome as well. Any other thoughts or again, commentary on this? We've had some rich discussions. There was a really nice report that everyone was able to review in the pre-read, conversations from the breakout sessions this morning. Great summary from Robin and story from Maddie. Anything else we want to add? That again, what we're really our job here, and the reason why we're having this conversation is because you've got our team is listening in and saying, hey, wow, that's a place to hunt. That's a place where we really think we can make a difference. So you guys just got, that's our role. Just throw it out there if you think it hasn't covered yet, so that we can really give some direction here.
Edmondo, $20 million is not a lot of money, to solve this kind of really, as you said, BHAG problem that we have. And I would maybe even submit that we know how to fix some of these things, right? I mean, the breast cancer centers work, the heart failure clinics work. It seems to me this is a condition, whether it's Coxsackie or some, EB Epstein-Barr, it is something where no one has taken ownership to run that multidisciplinary practice. Where whether it's infectious diseases or somebody's got to take ownership to say we're the quarterback and we're going to have everybody follow us. And bring those specialties in. Just like in transplant clinic, it works because you have the dietitians, the physical therapists, the radiologists, the cardiologists, nutritionists, cardiac surgeons, all working together. So this is not something where we have to invent the wheel here, whether it's for payment, data, or care models or protocols. But what's hard is it's a condition where who wants to run the POTS clinic?
Got you. Kathy, I saw your hand pop up.
Yeah, we need a definition. I think we're gonna have a difficult time assigning ownership until we have a really good definition of what long COVID is, and other symptoms that are associated with it that may not be as common, but it seems like that must be a foundational place to start.
Yeah, and it was one of the first things that is often actually brought up around this, which is just really the frustration around not actually, both on the clinician side and definitely on the patient side. What is this? What are we talking about? How do we define this? No, it's critical. David Schmitz, and just so you guys know, I've been calling David Myers, David Schmitz doctors because there's like 3 Davids on the call. So otherwise I colored them their first name, except it would get confusing. So that's why I'm doing that.
Thank you for that. There are a lot of Davids. I was just going to say, I think that really making this a distinguished and important diagnosis of study. So what if we look at any of the capitation model studies, if we look at CPC Plus, which I had a facility participating in, just calling that this is an important area of study in itself as a definitive quality measure, I think would be helpful, because until we really, our part of the problem of fragmentation is that there isn't the capitation model to follow the patient over long term and long distance. This is even more complicated perhaps because of the quotient of the potential for disability and the savings, not only for the healthcare system, but for the society at large in earlier diagnosis and treatment. And I think the story that we heard was a really good case example of that. And so that calls the bigger question of what value the healthcare treatment brings to society, which I know could be difficult for us to address. But at least if we started with a capitated model that looked at this as one of the quality outcomes, that would be helpful.
Really great point. Yeah, is it difficult to measure? I think you're right. Yeah, it might be challenging to measure, but imagine again, just take Maddie's story. You're with her traveling all over, trying to just take care of herself in this. You're taking a nurse out of our market, out of our healthcare ecosystem, as she's trying to navigate her own care. We already know we have nursing shortage, and she's specifically with a PACE program, so she's taking care of really vulnerable patients, and we're just like, nope. You're going to take you right out of there. She loves her work. I know because I talked to her. So she loves what she's doing. She wants to do it. And instead, we took her out, and we're sending her on, this journey that's highly uncoordinated and suboptimal. So there is value there that there's opportunity costs, let's call it, there that we haven't quite called out, but we should at least put that on the table in terms of, if we're going to think about investing in optimizing our care, we should also understand what the opportunity cost of not investing in doing this well would be. Sorry, Maddie, I didn't want to speak for you too much, but I know that when we chatted, that was, I felt your passion for what you do with your patient, and so
that's the point. Thank you.
Come on, I think you're back up.
I'm really appreciating this discussion, and as an improver, one of the things that I've been thinking about is, well, in this very large complex problem, are there particular subsets or particular populations or particular things that are perhaps easier to target, or in the spirit of start small, learn, and then scale, that we can potentially learn from, and sort of in the spirit of what was mentioned, sort of quick tests of change, learn. I don't have an answer on what kinds of groups, but I imagine people who are in this space day to day might have some thoughts on that.
Yeah, it's a great call, and potentially a model to get, like you said, just to get started, get some traction, get some, what we like to call, again, from an improvement perspective, some quick wins, right? Let's get some quick wins and see if we can't actually make some progress on the topic. Other thoughts? Here's what I'm going to do as we come to the, towards the end of this part of the conversation. And we heard you. Now you've heard us having the conversation. I'm actually going to give you guys a chance to close this out. So Robin, first, based on what you've heard in the discussion, any closing? I know I'm putting you on the spot. I didn't give you a heads up on this, so apologies. But any closing thoughts that you guys might have based on our conversation here?
Totally fair to put me on the spot, Edmondo. I'm happy to chat. So first, I think everything we talked about, and to come back to what you said, this isn't just about long COVID. So anything that we learn about or learn from treating long COVID can and should be leveraged into other spaces, right? So I think that's incredibly important. But second, that not starting from scratch, we have learned quite a bit in other disease states about how to take care of patients with very complex conditions, about how to bring folks together. We even have some examples of how to use alternative payment systems and alternative payment models to do that. So anything that can be learned from there to bring it back to long COVID and to generalize so that it can be used. Long COVID is not the last time we're going to face this kind of a challenge.
Yeah, no, great summary. Appreciate that, Robin. Maddie, I'm going to give you the last word here.
Great. Yes. And I just want to say thank you again, that I have had the opportunity to be a part of this. I think the fact that we are all gathered here together talking about long COVID is the right step in the right direction, because it means that we all recognize that there is that fragmentation, that there is room for us to enhance and improve. So I think, again, it's very important work. And I think those common themes centered around, the access to care, the fragmentation in care, but just recognizing that there is a problem, and it relates to things like we've said, more than just long COVID, that we really have an opportunity here to learn from each other and to address these things and improve not just the treatment of long COVID, but other things. So again, thank you guys so much. I'm grateful to be here.
Awesome. Thank you both for setting us up and for bringing us home for this session. Really rich conversation. I know the team was furiously taking notes and capturing this, and really it's helping them frame up next steps and where we're going to move forward here. We're doing really well on time, and we do have public comments. So if the person's on, I'm going to call them up for public comment. I believe the public comment is going to come from Michael Sieverts. So you've got 3 minutes. Please start by introducing yourself, and then you've got 3 minutes.
Okay, thank you. So just double check that you can hear me. Thumbs up.
Yes, we can hear you.
Okay, good. All right, so I'm Michael Sieverts. I live in Arlington, Virginia. I had my acute COVID infection in March 2020, my first waiver, and I've been dealing with long COVID since then. So I'm coming up to my 3-year anniversary. And like Maddie, Hashimoto's came out as coming out as part of my long COVID journey. The thyroid therapy has helped, but not made a huge difference. I was motivated to speak based on the first part of the discussion I heard, although the conversation got much better at the end, but it was the notion that long COVID is new. And I was glad that Dr. Ting and others reinforced that, no, this is just the most recent and perhaps the largest occurrence of an infection-associated condition that we've seen many times in history. And the pattern with long COVID is not different from what we saw with SARS in 2003. And if you look at the recounts of the 1918 epidemic, it's there. And it's been, many people end up with these kind of debilitating chronic conditions following EBV, mono, other illnesses, chronic Lyme is related. All of these infection-associated conditions, throw your immune system off and leave you in this, very limited state. So and the other thing I want to make sure was mentioned, because I didn't hear it, is the term ME/CFS, myalgic encephalomyelitis, chronic fatigue syndrome. That is perhaps the most common and most debilitating of these infection-associated conditions. I have it. It makes my life quite limited, but that's I've managed to set up and get through the days okay with that. I also want to mention, so I heard some people alluding to better tests, better technology. That's all important. I will say that I am part of the intramural studies on the NIH campus. So I've had lots and lots of tests run. Basically, any standard blood test is not going to tell you much. The tests that have been interesting for me have been spinal fluid analysis and some really interesting analysis of markers on immune cells, T cells and B cells. Those aren't the kinds of things that are going to be run in most doctors' offices or most regional, most commercial labs at this point. So just think, just assuming that there's going to be a diagnostic test that's going to get you there quickly is probably wishful thinking. The tests, the complexity of these conditions is so significant that you really have to be able to step back and do thorough analysis. And in the absence of that, do a lot to understand what the patients are actually experiencing. Work with what the patients are telling you, the patient's experience, and that can get you a long way towards helping patients. So thank you.
Thank you. Really appreciate those comments. So let's move on to the next part of the meeting, which is really the wrap up. So yeah, I get to just decide how we're going to wrap things up. And if you guys haven't picked up the theme yet, I literally make it up as I go. So, but it's been such a rich conversation. And we've talked about, let's go back. Obviously we most the freshest thing on our minds is the conversations around long COVID and fragmentation, but we also talked about the patient safety framework and the patient safety action alliance and our opportunities there. And we led off technology issues notwithstanding with Dr. Valdez's summary kind of highlights from the agency. So, kind of taking that all in mind, I'm really talking to give you guys a minute to think here, because I'm going to go and I'm going to call on each of you. So prepare. What are your takeaways? And here's how I think about takeaways. It's I've called them themes in the past, but is the idea that optimally it would be, is there something a thread that I can pull through everything I heard and learned and discussed today that I can then pull it all together? It, again, as I mentioned last time, it does not have to be in haiku form, but the idea here is that, is there something that you've can pull together? If not, that's okay. But really summarize the day. What's your takeaway? What are you walking away with? And maybe even more importantly, what do you want the art team to walk away as we close out this NAC. We only meet a few times a year, so this is the time to kind of make these kind of summary statements. So we'll walk through that. And I'm going to call on all of you so that you guys are prepared, preparing yourselves here. Of course, the person who gets to go last gets to hear from everyone else, and it makes it easier. But I'm gonna randomly call on people, literally based on what's on my Zoom screen right now. So Kanan, you're up first.
Really appreciate it, Edmondo. Yeah, so the takeaways. I think when you have something big, complex, as the ones that we've talked about thus far with long COVID, with no clear-cut strategies on how best to tackle it, the takeaway for me was to do two things. One is to take a step back, look at the bigger, broader picture in terms of what needs to be done. And second, more importantly, the voice of the customer, listen to what the patients are saying, see what needs to be done from their perspective. And it's all about them and not about us. And so what needs to be done from that perspective. The second, related to the Patient Safety Alliance, I think it's the right move, just making sure that we are not duplicating efforts of what other patient safety organizations might be doing. And whatever the Action Alliance comes up with, complements, supplements things, rather than reduplicating efforts on other aspects that might be ongoing at this point. So those maybe are the two big ones that matter.
Great, thank you. All right, next up is Aji.
Okay, so I'm thinking about all the pieces here, and in terms of translational science, we know we have CTSA by NIH. Then there's a whole spectrum from T0, T1, T2, T3, T4. And what we are talking about here today, I think most of the work at AHRQ is actually T4 and beyond, which is to disseminate and do the implementation and measured outcome to make real impact. I think that's probably, we all know that that's very important. So the recommendation I always have AHRQ is that to get more funding because it's so important. And as we mentioned earlier, $20 million for data, I mentioned that's almost nothing. And to really make a committed impact. And we need a framework. I think we already have. I think what we need is actually to put everything together into the community to actually make impact, whether it's long COVID, fragmented care, or diagnosis.
Yep. Thank you. Great points. Neil, you're up.
Yeah, I'm struggling because I'm going back to where we started the conversation that what we've talked about with long COVID is really just another indication of an overall fragmented healthcare system. And I'm concerned that if we focus too much on long COVID and not on the basic underlying problems like inadequate training or inadequate modes of communication or inadequate primary care or lack of accountability for outcomes or needing to change the payment model. If we can address any of those, will benefit people with long COVID and people with cancer and with all the other diseases that we've talked about. So, it's important to recognize long COVID as a significant problem for people who are being affected by it. But a lot of the issues can be addressed by going back and saying, what's it going to take to fix the broader healthcare system?
Oh yeah, that is definitely the challenge here. Kathy.
Yeah, well, Neil took my fragmentation comment, so I'm going to just agree with him. But the other thing that I'll say is the real need to really think critically and comprehensively about care models, and that's who are our healthcare teams, what do they do, what do they contribute to patient care, how do we attribute that, and how do we think about different reimbursement models so that all members of the healthcare team can be reimbursed and seek reimbursement for the care they provide.
Very good. Where am I at? I'm at David Schmitz.
I really agree with Neil, so I won't restate that. And then the only thing I would add is just the idea. What I want to leave with AHRQ is the risk of unintended consequences if we don't hear from diverse voices and potentially marginalized populations. So sometimes what seems like a great solution actually can detract from healthcare delivery in certain settings. And so I really think that we did hear today of a failure of healthcare delivery in a rural setting, but I want to emphasize that rural communities can deliver exceptionally high quality healthcare, actually. And I would hate to see a centralization of resources in lieu of actually strengthening what is oftentimes a backbone, which just needs a little bit of augmentation to deliver that same care much closer to home.
Gotcha. Message received. Andy.
Yeah, my through line is like the previous 4 speakers about the role of the health system in long COVID, and the opportunities that produces or provides for AHRQ to really discover how to deploy things like telemedicine or remote monitoring. I think it provides a through line, a kind of a useful high priority lab to test those things, which are kind of useful for needed for other parts of the health system. Also return just to my other, just the opportunity to really enforce or innovate around the learning health model in this, because it is a high priority area. There's lots of science being discovered, biological science, as we all think about the T4 end of the spectrum, and the opportunities there seem pretty significant for us to think through.
Yeah. Henry.
Thanks, Armando. I'm actually feeling inspired and hope with these conversations with really smart people in the room who are trying to solve really complex problems. And that's a good thing. And I think that, what we need is actually much more innovation and transformation, and to think about how to solve these complex problems really differently. I'm drawn back to my old, my old boss at the Mayo Clinic, our CEO, who wrote the book Think Big, Start Small, and Move Fast. And I think it applies to many things we discussed, not to consider the old way we've done things with the 20 million we have, or these NACs and snacks. It's really, when confronted with developing a test for the novel coronavirus, how do we deal with that versus how we're dealing with this issue, which we've all admitted has been going on for decades, yet we have not been able to approach it. And I think someone will solve it, and it's a solvable problem. And how we solve it, and the speed with which we look at starting small and moving fast before we scale quickly. And I also put in a plug that it's the connections, it's the knowledge to solve these problems all exist. And it's trying to build those bridges and connections. And that includes public-private partnerships, as well as different agencies within the government. So I'll stop there.
No, that's good stuff. Very good. Let's go with who's Kamal, you're next.
Thanks, Armando. My comment actually is nicely timed after Henry's, in that there is a feeling of sort of inspiration and hope. My brain often copes with haikus, so I'm going to share one and then add some more comments. Address complex systems together with clear purpose, COVID, safety, and beyond. And I think for me, if I channel Asaf's comments at a previous NAC where he was like, dare to think big, right? And the fact that we are convening a SNAC for the purpose of planning and prioritization and inclusivity, I think is a wonderful thing. As Henry mentioned, the fact that multiple HHS agencies are partnering together and there's different synergies that are coming through. We need to be able to address these complex problems, and I feel hopeful with some of the conversations that we've had at this NAC meeting and previous that we will be able to do that.
Yeah, that's great. And you keep setting the bar with these haikus. So appreciate that. All right, Krista, bring us home on our summary.
Well, just two quick comments. One, I am thrilled the importance AHRQ is putting on patient safety, starting a snack committee. I'm very excited about that. And of course, we're talking about how the healthcare system is so fragmented, but how important that patient voice has got to be at the table to make a true difference. And my takeaway is thinking about what models would look like and solutions to solve these issues.
Yeah, really, really, really good. So I'll just add great summaries of one, really good presentations and conversations, and quite frankly, complex problems. And so I appreciate Henry, for example, saying, "Hey, you know, I'm feeling a little hopefulness here." I think that's really good, and I think that means that this conversation actually has moved the issues forward. You know, I think about, for example, one way to approach it. You know, me being a general internist and a hospitalist, I think about if I have a patient that comes in to a cancer hospital, right? If you think about what I take care of clinically, it's always a presentation, a symptom of a systemic problem, right? That's what I take care of. The patient's not coming in and saying, "Hey, that immunotherapy that I took is causing this inflammatory process in my lungs," and that's not how they present, right? They present with "I can't breathe," right? They present with "I can't breathe." My job is to understand that that's a symptom of a systemic challenge that I've got to figure out how to address. Is it high dose steroids, whatever it might be. So thinking about long COVID as a symptom of the systemic challenges we're having across the healthcare system, in trying to find that balance between, because this is what I'm hearing from you all, there's this balance between this hyper focus on the long COVID, right? Like, fix their breathing, right? I could just intubate them and they could breathe better. But that's actually not the problem. The problem is they have an inflammatory process, and if I gave them steroids, that would help a lot, right? And so hyper focusing on the symptom versus the actual systemic challenges, but not trying to boil the entire ocean, because the systemic challenges are systemic and large for a reason. So where's that balance? And that's going to be, I think, the challenge for the AHRQ team, is to find out not only where that balance is, but where does AHRQ influence that? Where do you move forward, given the challenge of that balance of, wow, this is long COVID versus we're talking about really big, hairy challenges here. And I'm always gonna bring in that equity lens across, as it goes across that. Every time you approach these things, you think about it with an equity lens. The other, I really liked, Henry, the comments from your colleague, your former colleague, around think big, start small, move fast. Especially think about I think you mentioned the testing with COVID, but one of the things I think about, and I think this is a theme as well, is the vaccines, right? Because, like, how did we come up with vaccines that fast? It's because we didn't start from scratch, and we took it from a totally different set of why was it originally, what was the original research? And the original research was decades in the making, right? And we said, wait a minute, I think that'll work over here, right? So what's that parallel in terms of what we're trying to accomplish here, in terms of saying, wait a minute, there's something happening over there, I think it'll work over here. And I'm not just talking about long COVID in this case. I'm also talking about the patient safety work, right? That David and Aaron presented. Where you're saying, wait a minute, that worked over there, that'll work over here. Right? We learned a lot from the airline industry, for example, around safety. And so, so I'm not just thinking about different clinical challenges, but what are some of the industry, cross-industry fertilization opportunities around a topic as critical as patient safety. So those are a couple of my takeaways from your takeaways. So I appreciate you all jumping in there. And David Smith, I'm going to give you a word because I saw your hand up.
I just want to say what a great job I think you do summarizing and really telling the story of what we're doing here. And my comment to your first point of where do we start? let's apply the triple aim, the quadruple aim. Everybody agrees we want better quality care at lower cost. So that would be the lens where I would start about how big and how small we should be starting.
That is a North Star. And I think that's a very valid way to start these kind of conversations. So I want to, at this time, thank our speakers. So that was Dr. Valdez and Aaron Grace and David Myers, Maddie Smith and Raman Weinig for their presentations. Thanks all the NAC members who were able to join us and spend the day together. Just a note, the next NAC meeting is July something. Jamie, help me out here. July 12th. July 12th, yes. Sorry, it's July 12th in person, if at all possible. So that is, I think those are
in person for NAC members, Armando, not everybody.
Oh, I'm sorry. Yeah, sorry.
Yes,
For
in
NAC
person
members.
for NAC members.
In person for NAC members. Yeah. Yeah. Thank you for the clarity. That's why she stays on to just to make sure I don't trip over myself as I navigate these meetings. Is there anything else from a logistics perspective, Jamie, that I need to cover before we before I ask for a motion to adjourn?
No, I think you covered it all, and we'll resend out the slides just because I know Dr. Valdez's presentation got a little cut off, so we'll make sure we resend that as well as the important links that we communicated today.
Gotcha. Great. So with that, I will ask for a motion to adjourn.
So moved.
Second.
And a second is so moved and seconded. Any objections? Hearing and seeing none. This meeting is adjourned. Thank you all and see you next time.